And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of I will rise, we will rise, we will rise, we will rise up in spite of
Hello, my name is Michelle Zabel and my pronouns are she and her. I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. Today, I'm just delighted to welcome you to this Training Institute live workshop. As you might have come to expect with all your favorite conferences, the Training Institutes are now virtual. And although I know we'd all like to be together in person, we are excited to host the virtual Training Institutes and really want to encourage you to continue to join us on the first Thursday of every month through August. Each month, you'll have a choice of 2 back-to-back workshops. So mark your calendars, choose your workshops, and make sure you reserve your place early so that you can attend the workshop that most interests you. Today, I want to encourage you to actively participate by using the chat to post your questions, post your comments, and share your resources with your colleagues. Our presenters, they definitely want to hear from you. And it is absolutely your participation that will make each of these sessions a success. As a reminder, staff are monitoring the chat and they're going to make sure the facilitators see your questions and comments, so be sure and engage. A few other reminders to include: if you need assistance at any time navigating through these virtual spaces or accessing links to workshops, we do have a live help desk support standing by to assist. We are also providing a certificate of attendance after the completion of each workshop, and all of our workshops are being recorded, so by you participating, you're implying consent. Finally, there will be an ASL interpreter or closed captioning available during each workshop. Those interpreters can be pinned when available for those who require interpretation by hovering over the interpreter's video and selecting the 3 dots. One of the options that will appear is pin video. By selecting the pin video, this video will not move out of view. Following the workshop, we will have a wellness and mindfulness break with guided activities before our second afternoon session. With our theme, What Could Be? Bolder Systems and Brighter Futures for Children, Youth, Young Adults, and their Families, all of our sessions will challenge us to envision a future where the voices of children, youth, young adults, and their families are elevated, especially those who are most frequently silenced or marginalized, where we use the best data and research available to challenge ourselves, developing new ideas and approaches that can be implemented to meet the needs of youth and families, and in service of our commitment to social justice and the elimination of disproportionality and disparities. My hope is that today's session will provide you with food for thought as you consider your next steps in creating a vibrant, equitable future for youth with complex needs and their families. Please don't forget to register for next month's workshop. Remember, they're held the first Thursday of every month, and you can visit the institute.umaryland.edu for the full schedule. Thank you so much for joining us, and I look forward to seeing you next month.
Thank you, and welcome to our workshop on helping youth and families during COVID-19, a trauma-informed approach. Next. I'm Christopher Bellanci, and I'm an assistant professor at Harvard Medical School and the vice president of policy and practice and chief medical officer at Judge Baker Children's Center. With me today are...
Hi, I'm Kim Batchy-McKenzie. I am from Michigan. I'm the Division Director of Mental Health Services to Children and Families in the Behavioral Health Administration in the Michigan Department of Health and Human Services.
Hi, and I'm Mary Lubke, and I'm the manager of the Innovative Services section in the Mental Health Services to Children and Families Division at the department, and work with Kim.
Hello, I'm Laurel Omland. I'm the director of the Child, Adolescent, and Family Unit in the Department of Mental Health in Vermont.
Next. So I'm going to lead us off by talking a little bit about where we stand in the pandemic, about a year into the pandemic at this point, sharing some data from both the early, middle, and later stages of the pandemic. And then I'll be turning it over to Mary and Kim to talk about what they've done specifically in Michigan. And then Laurel will finish up talking about her experience in Vermont, specifically addressing the needs that I'll be highlighting in my part of the presentation. So I thought I'd just start by, where are we in the pandemic? As of the end of January, there have been just shy of 3 million child COVID-19 cases reported in the country, with children representing about 12.8% of all cases reported nationally. So it's still quite significant. And just as we saw in the general population over the winter months, we've seen an increase in child cases. Relative comfort that we get from this, if there is any comfort to be had with that kind of number of children testing positive or developing symptoms of COVID, is that children seem to have less physical manifestation from COVID. So very, very low mortality rates. Children were somewhere between 0% or 0.21% of all COVID-19 deaths, with 11 states reporting no child deaths from COVID. Also very low hospitalization rates, as low as 1.2 to 2.9% of all total reported hospitalizations were among children. So not that we necessarily celebrate that, but it gives us some comfort. When we start thinking about what is happening in the behavioral health space, we've got an issue where there's growing need and decreased supply. And this is really the critical aspect that I think we want to focus our workshop on addressing today. So from January to May, for the Medicaid and Children's Health Insurance enrolled youth, there was significant declines across the board in terms of what kind of services children were getting due to the pandemic. So there was a 40% decline in health screenings, a 75% decline in dental services, a 30% decline in children receiving vaccines, and then a 44% decline in outpatient mental health services. And what we saw as states and communities were starting to open up again, we didn't necessarily see all of those numbers return to their previous baseline. We also have concerns that there's been a decrease in reports to abuse and neglect hotlines across the country. They went down as low as 50%, and I'm still seeing numbers suppressed from their pre-pandemic baselines, somewhere around 80 or 90%, depending on the jurisdiction. And then there was also a Center for Disease Control report that does a surveillance scan. Since we're only about a year into this pandemic, getting hard research data is difficult still. And so it's the surveillance system that the Centers for Disease Control has in place that helps us to try to detect trends in what's happening across the country. And it was the CDC report that showed that the percent of emergency room visits for behavioral health reasons increased 31% for 12 to 17-year-olds and 24% for 5 to 11-year-olds from March to October in 2020 compared to the previous year. So clearly children are still showing up, and when they show up, anecdotally what I'm hearing is they're pretty ill. They have significant symptoms of suicidality. We're seeing significant increases in anxiety, in depression, and then also substance use disorders and overdoses. And in increasing numbers, we're concerned that these overdose deaths or overdose situations are related to suicide attempts and not inadvertent overdose fatalities. Next. So what are we seeing in healthcare spending that could be a guide to what's happening in the broader environment? There was a 38% drop in April of 2020 compared to a year ago. In June, it was not quite as low. So there was definitely an increase in healthcare spending, which is a proxy measure for are children seeing their pediatricians? Are they getting their pediatric care? Primary care practice volume was improved to 70 to 80% of the pre-COVID volume in July and August. So again, a trend last summer where things were starting to get back to not quite normal, but closer to what we had previously seen. Telehealth visits actually declined after a big increase as behavioral health practitioners all made the shift to telehealth. We started seeing a decline in April to only 20% of visits in July. So 69% of total visits were being done via telehealth in April. That went down to 21%. And again, this is primary care. This is not specific behavioral health data. So what that might imply is that some patients and providers prefer in-person visits. And when you think about behavioral health, where you might have to do lab tests or give vaccines or do something that's more hands-on than we necessarily do in the behavioral health space, that would make sense. What's less clear is what's going to happen with behavioral health after the pandemic. I'm hearing lots of families really preferring behavioral health via a tele platform. Decreases time trying to get to the provider, trying to pay for parking associated if you're in an urban setting. For rural settings, you can often talk about long distances being commuting to try to get to the provider. So there's an opportunity in this crisis to try to see, well, what works best in the behavioral health space in a tele platform? And then what do we want to see continue in terms of increasing access? Because I think this could be the potential opportunity to try to increase access to both historically underserved populations in rural settings, and increasing access to providers who may have a skill set in evidence-based practices that we know is often so hard to access. So thinking about creative ways to use this crisis as an opportunity to build out services and supports that previously we may have been wanting to do, but had never been either forced or compelled to bring to scale. Now that we have, what ways and how and which specific interventions work best in a telebehavioral health platform? I'm finding that behavioral health interventions that have a strong evidence base that often involve teaching skills and coaching is working very well, and perhaps even better in some cases to office-based visits for telebehavioral health. And then we also want to keep an eye on reimbursement rates. A number of jurisdictions made sure that telebehavioral health, remote behavioral health options were being funded at the same rate as in-person. And that's going to be critical if we really want to see this adaptation take hold post-pandemic, that we don't see the rollback of those time-limited opportunities where there's equity between behavioral health delivered via a tele-platform versus in-person. Next. So another CDC survey from June. Now this was a surveying adults, so it was 5,412 US adults. But what we saw was a really dramatic increase in adverse mental health and even behavioral health and physical health stress levels. So almost 41% of adults were reporting at least one adverse mental or behavioral health condition, including depression, anxiety, post-traumatic stress, and substance abuse. And these rates were 3 to 4 times higher. This is an annual survey that the CDC does. So we had these baseline data that we could compare. And what was really dramatically impressive to me was they asked in the last 30 days whether you had seriously considered suicide. And almost 11% of the adults in this survey, and this was a random survey, this is not a clinically identified population, were reporting seriously considering suicide. And when you looked at the subset of 18 to 24-year-olds, that number went up to almost 26%, 25.5% of the young adults surveyed in this larger survey had seriously considered suicide in the last 30 days. And we know if adults are struggling, then so are their children. Next. So I focus on millennials because they're now of parenting age. So these are folks that were born between the years of 1980 and 1994, and their ages were 24 to 39. So nearly a third have a behavioral health condition, and their rates were rising by double digits. So rates of major depression, alcohol use disorder, tobacco use disorder, substance use disorder, and ADHD were all rising. And the 5-year prevalence rates for depression were 43%, for an alcohol use disorder, 5%, In tobacco use disorder, 10%. In ADHD, almost 40%. Next. And then the impact of COVID on this parenting age cohort of adults, we're reporting a 34% increase in alcohol consumption, a 20% increase in smoking, a 17% increase in vaping, a 16% increase in non-medical drug use. And their perceptions of their mental health were significantly negative, with 80% reporting their mental health has had a negative impact also on their physical health. And then deaths of despair, as I had noted, were on the rise, which was already happening before COVID. And so the pandemic stress was not landing on a blank page. And this was particularly true of Black and African-American teenagers, where we had been seeing a steady increase in their suicide rate, which had been relatively lower compared to white identified youth previously. Next. So in essence, we're going to be facing, or probably already facing, a second behavioral health wave. Rising rates of mental health disorders and substance use disorders, the disproportionality of the impact on Black, Brown, and Indigenous families, families from lower socioeconomic status, older adults, and frontline workers, all were, I think, clearly disproportionately impacted in terms of both rates of COVID infection as well as deaths from COVID. At this point, we're somewhere in the mid 400,000s of Americans who had died from COVID, and that number is continuing to rise, although at a little bit of a slower rate in the last week or two, which is good news. And the COVID numbers, the rate of COVID infections are coming down somewhat as well. It's estimated that for every COVID death, it's leaving as many as 9 family members bereaved. And the complications of bereavement in the period of a pandemic are also adding to what we all need to be thinking about as behavioral health providers and caregivers in terms of how we think about our response. Because what we'd like to do is head off complicated bereavement from becoming post-traumatic stress. And those usual rituals around families coming together to mourn family members are all being disrupted. And while we try to come up with creative, remote ways of coming together and to do so safely, those are less clearly effective in facilitating a mourning and a grieving process. And so the grieving itself is also very complicated, complicated by children not having access to their support community that's often through school or being able to play outside with their friends, et cetera. Again, depending on the level of lockdown or physical distancing that's required in your specific community. And it's not just the pandemic. We've also had a year of hurricanes, fires, floods, racial trauma, political turmoil. And that's all adding to what I'm experiencing in my community as just a universal level of stress across the board. And that even in previously high functioning, well-functioning, well-resourced, good coping skills kinds of folks, the burden is such that just don't ask them to do one more thing. Just don't ask me to do one more thing, because I think people's reserves, their tanks are just so empty in terms of their resilience. And what we really want to do and talk about today is how do we build resilience from a trauma-informed perspective? Next slide. So I found thinking about this from a public health approach resonated for me, and thinking about our tiered responses. And I think both Laurel and Kim and Mary will talk a little bit about the way they embedded that approach in their state responses. So starting with screening, preventing normal grief and distress from becoming prolonged or disordered. Although with high rates of impact like we're having, screening, you almost want to think about a universal intervention rather than kind of screening when we know that we're going to be triggering such high positive response rates, and then thinking about how we're going to triage the limited resources we have in the behavioral health space to respond to this unprecedented need. Mental health risk assessments. So what we're really trying to do, as I've mentioned, is return prolonged grief and post-traumatic stress to normal grief or distress trajectories, and really thinking about how to do that in the primary care space, how to do that through schools, to meet kids where they are still, hopefully getting some interface. And then treating those at highest risk, so to prevent both morbidity and then mortality. Next. So I also want to highlight that we need to be thinking about supporting our workforce. So that same CDC study reported that 22% of essential workers had seriously considered suicide. So twice what the overall adult population that had been studied in that report last June was about 10.7%. Here, twice as many folks who are essential workers had seriously been considering suicide. You know, and early child care providers, teachers, mobile response and stabilization service workers, or in-home therapists, they never really expected to be on the front line in a pandemic, and that their work was going to involve them potentially being exposed to a life-threatening illness. And I think we need to understand that and support the fact that we're asking a lot of our frontline workers, often of whom may not have the option to do their work in a remote way, or coming up with creative ways to do a hybrid kind of model. I've heard therapists talk about meeting students in the driveway, or meeting by the mailbox, or going for a walk, or finding all sorts of innovative ways to try to have some social connection while being physically distanced and safe. So how are you supporting the workforce that is being sent into harm's way? How have you adapted your direct services to ensure client, family, and worker safety? And what % of your children's behavioral health services are still being conducted virtually? And feel free to chat into the chat any kind of responses so we can get a sense as to what it looks like in your part of the world, in your community, in your work setting. How have you creatively adapted your interventions and your services to meet this unprecedented demand? Next. Now, there are ways in which this pandemic is different from other disasters that we have experienced. In one, it's been an unclear timeline. You know, when we first made the shift to doing all of our behavioral health services remotely, it was March 13th. It was Friday the 13th of March last year. I remember it quite vividly. And over the weekend, we basically tried to make the shift to all of our services being provided remotely. And I thought, well, you know, we'll do this for 2 weeks. We'll hunker down. This thing will blow over us, and we can start returning to normal. And here I am almost a year from now, from then, and still finding myself working in this office space and not doing the hands-on work that I'm so used to doing with children and families. So what we found ourselves in is not a sprint, but a marathon. And it's hard when that threshold, that finish line, just keeps being moved further and further. And I think that that can be really challenging in terms of how you manage assumptions, how you manage expectations. The universality of the risk. You know, it's not just happening to others, it's happening to ourselves. How many of you are simultaneously trying to participate in this workshop while also having your children remote learn in the background, or caring for or worrying about elderly parents and how to get the vaccine for them? And so the coping needs are really high right now. And the risk is universal. So we're managing our own response to this pandemic while also managing those, the responses of those that we care about and are caring for. The racial disparities, relatively unique in many disasters, clearly, as I've alluded to, both in terms of infection and death rates. And then the context. There's not been a consensus clearly on how we should be responding to the crisis. And that creates a lot of division and a lot of anxiety for folks about who should I be listening to, who's got the most accurate data, who's got the right data, and what is my personal responsibility as a citizen in a pandemic. Next. So how do we support resiliency? You know, there's a finite amount of adaptive energy to cope with stress. And we didn't go into this, as I said, on a full tank. Children look to their parents to know how concerned should they be. So how do we support the parents' resiliency and modeling positive adaptation and coping? Unfortunately, not everything that's stressful results in post-traumatic stress disorder, and actually can be an opportunity to develop this competency, this resiliency skill. So the greatest predictor of resilience is collaboration and cohesiveness. So in what ways can we play a role, either in the micro or in the macro, depending on our role in the children's behavioral health space, in creating those kinds of communities of collaboration and cohesion? Next. So we do have trauma-informed and responsive approaches and supports, and I think that's really what we want to emphasize. We also have evidence-based practices that are proving to be even more effective than telebehavioral health. So parent-child interaction therapy is one that the Judge Baker Center does, and we're finding the ability to kind of zoom into families and provide that coaching and reinforcement that we would be having to artificially create in a clinical space. So this is a therapy that's done behind a one-way mirror. The child and the family are in the room. The therapist is coaching the parent behind the one-way mirror through the things that are ubiquitous these days in our ears. Rather than creating that artificial environment or construct, you can do it right in the actual space of the family home. Parents who have been at home with their child who struggles with behavioral health challenges are highly motivated to practice and learn these skills. So we're also finding that it doesn't take a lot of convincing. We're also finding no-show rates are plummeting. So we have very high show rates, which we don't always see in office-based practice. And while physical distancing is necessary, it doesn't necessarily mean you have to be socially distant. So how do you create those safe virtual social connections for families to connect to other families and parents who may be able to share resources, share local offerings in the community, share what's going on in their school system, and just share, ideas about how to continue to engage each other and with their families and their children. What role does psychological first aid play? And what are the other strategies? So I'd be interested, again, chime into the chat on what you're finding to work well to build this kind of resiliency and think about trauma-informed responses to the needs that I've highlighted. Next. And then, as I've said, in any kind of crisis, there is opportunity to think about what have we learned from this crisis? What do we want to continue to do? So for those of you who are more research oriented or measure outcomes, be thinking about how to capture the outcomes from the switch to telebehavioral health that might highlight actually what's working best that we want to continue in a post-pandemic world. So what aspects of telehealth? What does telehealth work well for? What populations? But also who does it leave out, or is it less effective? And what kind of hybrid models might we want to land on? Given the nature of COVID, how do we prepare potentially for years of waxing and waning flare-ups? I think, I'm not an epidemiologist, I'm not an infectious disease person, but listening and reading a lot about what they're talking about, this may morph into what becomes a seasonal influenza. We may need booster shots. There's already discussion about when we start getting our teachers vaccinated, which are being appropriately prioritized in many jurisdictions, what does it mean since the students themselves are probably not going to be getting access to the vaccine at least until later this calendar year because they haven't been studied yet? Although given the numbers I started with, the relative low penetration of actual physical illness when they do test positive for COVID, there's some caution there. What's less clear is if you are vaccinated, do you have less chance of spreading COVID to others? And that's going to be playing into the discussions about when it's safe and appropriate to open schools for full-on in-person learning. And then how do we keep those in need of services engaged in treatment? Because, again, what I started off with, precipitous decline in both physical health and behavioral health services and supports initially while we made this shift. And then the question is, for those children that were getting services and supports through school, are schools able to maintain that in the virtual environment? Or are they primarily focusing on academic learning? And in the absence of that, what are going to be the needs of children, including all that lost learning time that so many of our children are experiencing? Next slide. So final thoughts, and I want to thank Francis Collins at the National Institutes of Health for these thoughts. We can stay socially close and reach out to each other in different ways. We are going to get through this. I think many of us are already starting to see a light at the end of the tunnel, but we're going to get through it in a way that will change us. So will we be changed by becoming stronger and more resilient, having learned some lessons about ourselves and about each other? That would certainly be our hope. And we cannot simply hide our heads under our pillows and wait for this to pass. When you wake up in the morning, say to yourself, I'm engaged in something that matters. I'm not just a passive victim of this terrible pandemic, and I'm trying to do what I can and work toward getting us through. Thank you. And now I'll turn it over to Kim and Mary.
Hi, this is Mary Lidke from Michigan, and welcome this afternoon. I hope you're in a nice warm place instead of looking out at a snowy community that I am at this point. But we want to welcome you to talking about what we've been doing in Michigan. Next slide, please. First of all, at the state of Michigan, we have, as I'm sure many of you do, at michigan.gov, a rather extensive web presence in our coronavirus website, including the mental health stay resources to help everyone to stay well. Now you notice it's also broken down for older adults and families and educators and frontline workers, because we know we have to talk to people across the board. This isn't just for, our consumers, it's also for everyone is challenged in this day and age. Next. We wanted to share with you some of the data that we've been mining recently. We have a snapshot of what Michigan during the pandemic looked like as far as telemedicine visits. Now this goes across all the telemedicine that was done. You could see in January and February where our numbers were, and then how it shot up, of course, in March and April. And then, of course, the trend down, that our number of people utilizing our unique beneficiaries, this is Medicaid data specifically, that is kind of flattening out towards July and August and September. And we're looking forward to getting our next quarter data very soon to see how that's playing out. But the number of visits per beneficiary is kind of staying in a similar curve as we go. Next. Now, specifically for specialty mental health, behavioral health services that we provide in the community mental health system, and that is for children with serious emotional disturbance. This is the trend that we saw in the first several months of the pandemic, that we went really at a very low number of telemedicine visits and shot up tremendously between March and April. Those numbers of actual visits are going down, and our number of beneficiaries or people using that, whether it's youth or adults, those numbers are staying rather consistent in Michigan at this time in our specialty mental health services. Now, part of this is that it could be what it's talking about here. You can see our beneficiary numbers here between January and September, and also the number of unique visits. And it's almost broken by quarter, really. In some ways, the numbers are looking very similar, but the shot, how it goes up from 4,000 in February visits to 50,000 in March, and then more than doubling in April. But as we go through the pandemic, we're going down. But that's also because I want to point out that we do have parts of the state that have gone back to doing in-office visits and home-based services. Now that's based on the area being determined, the number of new infections, the hospitalizations on the governor's list of 1 through 6. I don't even know what to call those, 1 through 6, the phases, and how you can step back as different infection rates go down and hospitalizations, which then opens up the area for in-home and in-office mental health services. Several of our community mental health have continued to do crisis face-to-face in office or in the community, depending on their areas. So let's move to the next slide. As most of you have faced challenges, and we have our set of challenges that continue. I really like Steve's reference to this isn't a sprint, but a marathon. And as those dates keep going out, that we're all back into working in the office or kids are back into schools, that sets its own set of issues. But everybody, as Steve talked about, everybody moved out very quickly, and I'm sure in your community. And we continue under a public health order that started in the fall of this year. And I got to say that the feedback that we're receiving is that, working virtually, you can have meetings, you can have phone calls with your supervisor or with your colleagues, but it isn't quite the same as working in teams or seeing each other or being able to do those quote unquote drive-by times with your supervisor. We also have challenges that we've had to deal with as far as ensuring privacy and engagement and access when there are a number of children in the home, why we're trying to work with mom and dad on their skill set, and they're having to wrestle with the kids getting ready for bed or getting out. But always that need for mental health services and supports are paramount, and we're trying to adjust how we're doing that engagement and ensuring privacy. And as always, we remind people that we're using HIPAA compliant platforms when we're doing video work. Audio visual is important, especially when we know that the trauma-focused cognitive behavioral therapy developers have said you need to be doing audio visual. It's not a phone-based for those evidence-based practices. So we have to have HIPAA compliant platforms. There is consistent worry among staff, and that continues to be a challenge about their own health and safety, as well as the health and safety of the families as they return from doing face-to-face or home-based services. Yesterday morning, I was on a video conference with some of our infant mental health home visiting providers, and 2 of the staff were just notified during our conference that they were exposed to a family that's tested positive when they're in their home visits. So this is an ongoing challenge. It hasn't gone away. People are being, tested on a regular basis. And now we have 2 staff in quarantine, back to only being able to virtual versus doing in person. Next. So we have an ongoing challenge, ongoing about the concerns about our families and their ongoing trauma during the pandemic, whether it's traumatic loss of a loved one or their ongoing concern. And there's just that also underpinning all of these mental health issues is the basic needs. So many of our families have lost jobs, have limited access to great food. And so how our staff are responding and trying to make sure that those basic needs are met. And also then when we hit January and some of the supports that were there and legislation so people weren't evicted or didn't have or had to then January 1st pay all their back rent, that posed another set of challenges in stable housing for some of our families. So mental health staff, case managers are working very diligently. It's a real challenge. Families, I have to say at times are reporting that they're tired. It's a virtual fatigue. They're working from home, doing virtual work. They're helping their kids with virtual school. So it's a challenge to engage them in some of our parenting groups or therapy in the evening, because not only the kids are fatigued, but they're also fatigued. We're getting that virtual fatigue showing through. There's a decrease in the length of individual contacts. Some of our home-based services, our average length of time that the therapist was in the home was well over an hour in a session. Whereas when you're doing telehealth, when you're doing telemedicine, virtual work, it's really difficult to engage mom, dad, the child, the infant toddler in a virtual session for that length of time. That's also going to be a challenge that impacts the cost of the service. So one of the things we're really trying to look at post-pandemic is what is that ongoing cost of making sure we have these options of face-to-face and virtual, but then how is that going to impact cost? So, and I think that Christopher also mentioned about access, when we're talking about doing face-to-face in a rural area, sure, it's a long way for staff, but our families haven't, during this pandemic, haven't had the luxury at times to connect. They don't have high-speed internet in their area at all, or don't have the access to tablets. And some of that's being worked out always, with their children in school and such. But that does impact their ability to engage not only with their primary care provider, their pediatrician for their young child, but also they're getting their mental health needs met. And we're really always wrestling with that. I hope in Michigan, it prompts a discussion that has started in our state legislature about the internet and having kind of a system in Michigan for high-speed access. So those are some of the challenges that we've kind of come up with. Kim, did you want to add anything to that?
I did want to say that in the early days of the pandemic, which was now almost a year ago, we really saw a decrease in requests for psychiatric inpatient hospitalization for children and youth in Michigan. I don't think we're unique in that. And everyone kept talking about the second wave and when it was going to happen. And we certainly saw a kick back up in Michigan when school started. So a lot of youth were not able to return in person to school. People are sort of tired of being socially isolated and being home. And they're also, it's virtual fatigue, but I think it's just the pandemic fatigue of sort of not seeing an end in sight at that point in the fall. So we really had an uptick again in Michigan of requests for inpatient psychiatric hospitalization, and that has continued. We have one state hospital in Michigan. They don't have a waiting list, but they have an admission pool. And there are about 40 youth that are currently in that admission pool that basically some of them are in emergency departments as we speak in need of psychiatric hospitalization. So just wanted to mention that in terms of challenges. Challenges for our employees, our providers. Some of the biggest challenges that we've seen in Michigan in terms of services have been community living supports and respite providers. And so there's been a lot of work done in Michigan around the direct care wage, and that has helped a little bit, but there's a lot of youth that we're having a hard time keeping safely in the home or community without some of those key services. So just want to mention those as well. Next. So on to the resilient positive solutions. Some of what we did is, as again, I know has been occurred in other states as well. The evidence-based practice models, we run many out of our division. Mary's in charge of most of them. And we had to quickly pivot, as many of you did, to online platforms, figuring out how to adapt and be really creative, keep people engaged like we are trying to do today. We even did a state conference, so that was pretty exciting. But we also really wanted to think about how do we take care of our own? How do we take care of those providing mental health services who are going through their own trauma responses? So offering webinars specifically to trauma-trained clinical staff and their supervisors. That link was shared and many others joined those trainings. We also offered some specific trauma-focused reflective technical assistance to some of the communities in Michigan that were hardest hit. So really trying to provide an individualized TA approach by offering up to many of our urban areas. Next. We had staff who were unable to continue to do their jobs because of balancing care needs at home. So we had folks on FMLA, and we, then everyone's kind of spread thin. There's a hiring freeze. You're covering for other staff. Created a lot of stress. The word of the week was overwhelmed. Folks were feeling very overwhelmed, and still are today as we speak. As Christopher mentioned, folks, I'm so impressed with the resiliency and adaptability and the creativity during this pandemic. It's been really what's created a lot of hope for us in Michigan, and a lot of inspiration for the future. As Mary mentioned, we're working hard on thinking about the future with our telemedicine policy. We are basically every service that we can deliver you are able to provide currently under a COVID-19 agreement. So, and you can provide those virtually, and that includes audio. So, for our state, we want to make sure that many of those services are able to continue, but we also want to balance that against what do families need, children and families need face-to-face or virtual. And we need to make sure that our rates are reflective of current telemedicine practice. We found that sessions are briefer, but still as frequent. Next. So as Mary mentioned, we want to figure out a way to make sure that we have equity in access to technology and internet. And there aren't the fund sources that we have are not ones that can be potentially sustained over time. So there might be funding that we could utilize initially, but how do we continue that Wi-Fi or that hotspot into the future for children, youth, and families so that they do have equal access to technology? So please put in the chat if you have good ideas about that. I'd love to hear them. We want to continue to provide evidence-based practices as well as evidence-informed practices to the community mental health system clinicians in the state of Michigan to fidelity. So, we've had to work with purveyors who weren't real keen on initially providing things virtually. So we've done a lot of that work. Mary's worked very hard on that. As I mentioned, we want to make sure that we're really balancing the needs of safety, but also the need of needing to see folks in a face-to-face way. Mary, anything that I missed that you'd like to highlight before we move on to Laurel?
One of the things I thought of when we were talking about, we need to address at this point is the number of practitioners. This is one of our challenges now and moving forward, the number of practitioners that have left because they're challenged with having children at home, not being able to feel comfortable doing their positions. I was seeing a report on the news that we shouldn't call it a pandemic, it's a she-demic, because a lot more women are leaving the workforce at this point during the pandemic than men are percentage-wise. And that's, I think, very much impacting our mental health, especially our early childhood mental health providers. So that's going to be something we're going to need to be upfront and addressing is those shortages that we are experiencing in some parts of our systems and some parts of our state. So that's something that we're going to have to add to the list of next steps and beyond.
Mm-hmm. Thank you, Laurel.
Thank you. So I'm, again, Laurel Onland from the Vermont Department of Mental Health. And I think all of us can relate to the broad concepts that Dr. Bellanci shared, but also the state examples. I don't know that either Kim, Mary, or I have anything necessarily unique to share, but I think just trying to highlight what does this look like, and then for us all to learn from each other about how do we continue to advance this. So just a really brief, I have a lot of information on these slides. I'm not going to go through them point to point. But in Vermont, we had a pretty early shutdown with our governor's order for stay home, stay safe in mid-March. And that included the closure of school buildings. Education, of course, continued, but the schools remained closed through the remainder of the school year. But I will say our governor and his administrative leadership team have been really committed to clear communication around the coronavirus. They're holding, in the beginning, it was 3 times a week. Now it's 2 times a week press conferences to share the data, to talk about how that's driving their decisions. There's a level of, I guess, humbleness and openness to that communication through the media that I think many of us Vermonters have been impressed with and have really appreciated. And he will bring in different leaders across the administration to address various concerns, including he's had our Commissioner of Mental Health join periodically to really talk about some of the issues we're talking about today and what that looks like for supports in Vermont. So as we went through the summer, similarly, there were a lot of creative ways of delivering service outdoors, using tents if there was bad weather. But then as we headed back into the fall and in Vermont, as it got colder and drove many of us back inside, our numbers have started to creep back up. So we had been seeing some economic reopening, if you will. Our governor delayed the start of school in September, but then it did get underway with all schools having some form of in-person learning. Most of them were in a hybrid mode. And then about a month later in October, our elementary schools opened up primarily for nearly full-time in person. And now our governor has a task force to look at how can we open all schools in a way that's safe, but also recognizing the impact it's having on the social, emotional, and obviously academic learning of our students. So that's just a very quick snapshot of what it looks like here in Vermont. I think the challenges are similar to the ones that you've already heard. There's high levels of stress, perhaps due to unemployment. There is isolation, depression, homelessness, that deeper level of grief without the typical modalities of processing. I think we are concerned about for kids and youth, their typical developmental steps might be somewhat inhibited. Toddlers and younger kids aren't with their peers and learning those social skills. Adolescents and young adults who are, more typically would be individuating and spending more time with their friends are more typically at home with their parents and trying to figure out ways to stay connected, or as we were hearing in some of our we have a Vermont edition where people can call in. Some families aren't following the health precautions and others are, and that sets up for some pretty challenging situations between kids and their parents. We also know that there is a lot of concern about higher risk groups. So we know that there are some LGBTQ youth who may be in unwelcoming families who feel much more isolated, and trying to figure out how to continue to have them be able to connect with other peers and supports in the community in virtual ways. And so trying to have some clear messaging around that. In Vermont, again, as I'm sure elsewhere, we are seeing more people calling crisis lines than had before. We're also seeing a lot of new people requesting clinical services than had before. And similarly, it's the duration of those services are reduced in that telehealth approach, but the need is tremendous. And as you can see here, there are a couple of quotes from our public mental health provider system just talking about it is stretching them. They are feeling the stress themselves. There's an element of, as I think it was Dr. Bellanci noted, we're all in this together, right? We're all experiencing it. We have our different experiences, of course. That does help with some of that connectivity, but the exhaustion is underlying it. And so part of what we're trying to think about, as I'm sure everyone is, how do we support that provider system? What are the tools we have to do that across the spectrum of the financial tools, as well as the workforce development and just other supports? So similarly, we have staff who have been having to stay home or are working from home with parenting responsibilities or due to their own illness or potential exposure. And that is impacting service delivery, it's impacting provider wellness. We're seeing broader impacts across our general system, as you just heard in Michigan, where we have some closures of some of our crisis beds and inpatient beds because of either staff availability or because of needing to comply with health precautions and not having the space to be able to have more of that distance. And so that kind of squeezing, if you will, of the available resources is definitely, we're feeling pressure from that in general across the system. I think another thing, so what have we done? What are some of the positive potential solutions here? Communication is key, as it always is in a trauma-informed approach. We want to keep that open communication. As I mentioned, those press conferences have been helpful. As a state system, we've also been having weekly meetings with all of the executive directors of our both public mental health and developmental and disability services providers, with our commissioners, and really trying to talk through what issues are they facing, how can the state help respond to that, and feeding information to and back with our health department consultants around all of this. So that's been really, I think, key. Of course, there have been tremendous actions around the policy development and guidance and trying to ensure that we are keeping up with how to adjust the delivery of service. And so some examples of what those have been here in Vermont in that box. We also have a fantastic child psychiatrist who is part-time with our department and part-time with our University of Vermont, who's really been active in a bunch of different media spots and trying to just publicly talk about how is this impacting families? What are some things we as adults and parents can do and caregivers, and just trying to get some of those core messages out. We also have a good focus on trying to figure out that provider stability, right? We need a mental health system to not just be able to respond now during the pandemic, but to be able to sustain and be available as the health pandemic starts to hopefully get resolved as we have more vaccinations, but the continued impact on mental health will continue to reveal itself. And so we hear about some in other parts of the country, providers having to close because they don't have the fiscal ability to maintain it during the pandemic. And so that was a real important part for us, was how do we maintain that fiscal solvency for our providers? And in Vermont, we are fortunate. We have a 1115 Medicaid waiver with CMS that we were able to leverage some flexibilities within to have continued prospective payments, and some other details that I won't go into, but it really has helped to keep more of a steady flow and financial predictability for our providers so that they could maintain their staff. We had slight furloughs in the beginning, but then they can get their folks back in so that we had a system who could respond to this need. I think the other key piece is that we've had tremendous partnerships across our system of care. And so really trying to communicate closely with our child welfare, juvenile justice partners, of course, with our health department and maternal and child health, and our early care and learning folks. Everyone was seeking input about not just what do we need to do for PPE and health precautions, but from a social, emotional, mental health lens of both the people they're interacting with and serving, but also their own staff. And so there was a lot of reaching out to our department for input on that, and continues to be. And I'll talk a little bit about a key part of that with our education partners. Of course, we've been keeping an eye on concerns around suicide risk and ensuring that we have suicide prevention efforts that are strong. Thankfully, have some federal funding to support us in that. And then looking to the parts of our system that already were in place and how can we leverage those in a creative way to continue to address this need. So one area we hear is that primary care, pediatric primary care providers are concerned. They're hearing concerns from the folks that they're serving, and still seeking, the primary care providers were seeking consultation around addressing that mental health need. And so we've put together an ECHO project. I don't know if folks are familiar with that. It's a way of having a panel of experts, typically in a more urban or university site, that can then share that information more broadly with rural providers. And so we've used that ECHO structure to provide information to primary care providers across the state around mental health. And it's still underway, but we have some great feedback from that so far. One area that's been, I guess, challenge in Vermont, and I'm sure elsewhere too, is when school buildings closed, that had a big impact on students' ability to access school mental health. And in Vermont, that's a quite robust system. And so there was a lot of quick trying to pivot to how do we ensure that those services can continue? And that led to some interesting challenges around this is essential service, and yet whose responsibility is it? Our funding structure in Vermont is unique, but it led to, whose risk is it? And is there equity of access to school mental health if those students aren't also able to get some other disability related services? So it got complicated very quickly. I think we've had a dedicated group of folks at both the state but local levels also coming together to try to resolve that, and everyone recognizing students' mental health was really essential during this period. And so we were able to continue to have both virtual and some in-person delivery of those supports. We had clinicians who were going out to students' homes, especially identified from the school if those students weren't showing up virtually in their classrooms, that we could provide some outreach and continued support with those families. The school-based clinicians also shared that it was, one of those silver linings was that they were able to really connect more with families than they had previously when this school shutdown happened and shifted to the remote, because the parents or caregivers were home. And so it led to a different level of engaging families in those students' mental health needs, and then supporting parents, coaching them somewhat in how can they support their child's mental health needs so that they can learn, because those parents were suddenly in that role of being the educating coach in the home. And so there was a lot of effort in doing some YouTube videos and other ways of sharing some skill content with caregivers. So I think I'll keep going. I think a lot of the positive solutions, you heard some from Kim, certainly. Telehealth has been essential and I think welcomed. The limitations around broadband are also being taken up in our legislature. We're fortunate to have some federal funding, but also some non-federal funding, because the federal dollars couldn't be used to help families actually purchase the technology, right? And so we did have some local foundation dollars that we were able to leverage to help get iPads and other technological components that families needed in order to be able to access their essential mental health service. And that was, really done based on need and acuity, but it was, I think, a really helpful and appreciated support at that time. There were some training resources for families about how do you do telehealth. I think that was another early on concern, that families might feel uncomfortable, not know how to do it. And so there was some intentional training of both staff, quite honestly, and families about how we can do this process. And that helped increase engagement, I would say. I think one other piece that I'll say is, and again, Dr. Bellanci spoke to this, but trying to track impact of this over time. I don't know about you all, but getting timely data about what impact this is having today on children is limited. Our YRBS wasn't held this year. I think it wasn't across the country. I'm sorry, that's the Youth Risk Behavior Survey. And the other means where we can track things like details behind youth who are waiting in emergency departments for mental health services, those are delayed data resources. And so we want to keep an eye towards those and help planning ongoing, but we're really trying to think creatively about where are the other sources of how we can understand today and now how children are doing. We do in Vermont use the Child and Adolescent Needs and Strengths tool. It's required for children served under our public mental health Medicaid system, and including school-based. And so that's been a helpful resource. And we are looking to use all of that data to inform what continued efforts do we need to focus on. So increasing some evidence-based practices around anxiety is an area that we've had some particular focus in this past year. And then again, caring for the caregiver, right? So what provider wellness activities can we continue to be focusing on beyond just training in a evidence-based practice? So our school mental health staff have been facilitating some wellness groups for school staff. And that was extremely well received, and is continuing to do some brainstorming with our Agency of Education about educator wellness as we head into planning for recovery from the pandemic. We've also sponsored a virtual training series for professionals around transforming trauma and understanding how, as clinicians, we can create healing communities. I have the first two here. We're actually beyond this, things get outdated quickly, but we have numbers 3, 4, and 5 are underway currently as well. And I think clinicians are really valuing that time to be able to attend to what do we as clinicians need to do in order to then be available to support the families that we work with. We also did some pivoting for virtual training for some of the other workforce development. And then through a federal grant have this COVID Support Vermont, which I think it sounds like many states are standing up, just call lines and support. I think we are running low on time, but I did want to just give a nod to many of us who are running some national or federal grants, and the pivot that we've had to do with that. This is one example where we had a grant focused on perinatal mood and anxiety disorders. We know that that phase is really essential, and we think about it during a pandemic. The isolation is even more layered. And so our provider system did some work to figure out how do we shift to doing some parent-baby yoga videos instead of some in-person classes, for example. And as well as just getting the message out and helping people understand that there are resources that they can access even during a pandemic from their homes to be able to manage their depression or anxiety or other stress related to that perinatal period. And then lastly, I need to acknowledge, of course, we are managing pandemics of health, but also systemic racism. And so as I've been talking with some of our community mental health, child, youth, and family services directors, they say, they're talking with their staff about how do you respond to a family who isn't following COVID precautions, right, if they're doing home visits. But they're also talking with their staff about how do you respond to a family who's engaging in hateful talk, or is displaying flags or signs that are disparaging to minority populations, BIPOC or LGBTQ. And so that is one of those would be intense. And to have both of those at the same time, and whether with the same families or just across every experience that some of these providers are having, requires a lot of supervision and support and resources. So one thing that we've been doing in Vermont is thinking about this crosswalk between I think most folks are familiar with SAMHSA's trauma-informed principles, which are listed here, with what we understand as the white supremacy characteristic antidotes. And so I'm going to show on this next slide, really trying to think about how to enhance our trauma-informed approaches, but with a racial trauma and racial equity lens. And so this is just one, I hope you can see it, but it's one example where we took those key principles of a trauma-informed system, and then there's a website which is listed on the bottom that shows what are the antidotes to white supremacy culture. And if we layer those together, what are those core components that we want to make sure are part of our service delivery, are part of our expectations of our workforce? And so from this crosswalk, if you will, we've taken some of those themes and put it into a new trauma-informed workforce and workplace assessment that our Department of Human Services is doing across our state of Vermont workforce. And so wanting to think about things like, as a supervisor, or does your supervisor have some of these concepts that have both the trauma-informed but the racial equity lens as well. So that's one effort that we're trying to do within our state government, but also then sharing that information out with our community providers through some trauma work groups that we have with them. And then I think the last thing I'll share is that we have a relatively new, I would say within a year, governor appointed racial equity director for the state, and she's instituted a equity impact assessment for us within the state government, again, to use when developing budgetary or programmatic proposals. And so the concept here is that through data-informed program design and careful consideration of compounded historical inequities, that the agencies across the state can craft these proposals in a way that align more with our state's values and meet individual and shared goals. And so those, I wanted to kind of underpin that, because I think sometimes, a lot of this essential work is happening on the ground level and in our communities, but it's also about how we set the tone at the state level. And so I just wanted to pass some of that on as well. And that is it for me.
Great. Well, thank you all. I think this was really useful information. I know I learned a lot hearing about the Michigan and Vermont responses. We did have a request, Laurel, for that resource to be added on the supremacy culture antidotes, the white supremacy culture antidotes. If there's a way to type that into the chat, somebody was looking for that resource.
I will try to. I'm not sure. I'm the one sharing the slides, so I'm not sure I can do both, but I will try.
Maybe you could just go back to that slide, and
Sure.
then we could have one of our able assistants copy it and type it into the box. So it appears down here in the bottom of slide 35. So I'm wondering, Neil, maybe you can type that into the chat for us. And this is also your opportunity for all of our 122 participants to chat any questions you have for us, so that we can engage you in the remaining time that we have. And then there was also a request for any specific resources that we could point people to on psychoeducation for families on how COVID can impact mood and behavior. So I typed a couple in. I always go to the Center for the Developing Child at Harvard University is a great resource. They also have a really great infographic on how racism impacts trauma, and how racial trauma is actually can be correlated to the early death that we see amongst Black, Indigenous, and people of color, by its impact on telomeres, which are these fragile ends of chromosomes that get more brittle under stress. And so he was very able to kind of connect the dots that we know exist in the adverse childhood experience study that shows greater childhood adversity is associated with greater morbidity or illness and then earlier death. And we're encouraging all of you to share what strategies that your state, community, or organization is using in response to the behavioral health needs related to COVID, or just in general, the stress associated with COVID. Kim, Mary, Laurel, any questions for each other or any responses to your presentations or to what I was talking about? I think it would be fine for us to also engage in a little chat amongst ourselves while we see what kind of questions come into the chat.
Christopher, this is Mary Ludke, and I just wanted to share, I think one of the things we've been trying to do too is offer the parent management training. Oregon model has a group model, Parenting Through Change, and we've been offering a lot of that virtually. And not only does that give skills to parents that we talked about and you pointed out in your PowerPoint in your presentation, but also it provides a venue for some parents to support each other. And I think in these days of isolation, not going out and doing some things with families or family vacations or whatever that have been somewhat curtailed, anything we can do to build that ability to reach out and support each other, I think is going to help us in the long run.
I absolutely agree. I'm wondering if you could add that resource in the chat. Because I was going to say, isolation is one of the greatest risk factors associated with this pandemic. And particularly certain cohorts of folks that are more prone to self-isolate if they have some social anxiety or children on the spectrum, What I'm also finding, from a resilience standpoint, is some of those young people are really loving remote learning. And I think the challenge is going to be when we actually go back to the in-person learning model, that their social skills may have diminished over this prolonged period of being out of the classroom. And so thinking about ways to make sure that we're keeping them socially engaged in whatever way is safe to do so in their community, because I think it'll be a bigger burden when we try to get them back into in-person and in social circumstances. Thank you, Mary.
Yeah, and I think the other thing, it just reminded me, we have infant early childhood mental health consultants that are working in early care and education and talking about some of the stress on our younger children, that they're seeing some of that behavioral. Now that the child care centers are opening up early childhood experiences, that the providers are having to deal with an increase in some of the behavioral issues in young children.
Mary, I think that's really key, is helping educators, parents, anyone who's working with children, no matter the age, to understand that the behaviors we are seeing are what we can see, right? We need to understand and ask and engage with the child, if they're of a developmental age where we can, what's behind that, because we know that there's a lot driving some of those behaviors.
Right. And I think our awareness of some of the inequities some of our children have been facing during this time, and whether or not that's economic insecurity, increasing concern about a pandemic they might not understand, but hear their parents talking, and also just that their whole kind of lifestyle has changed. Children do very well with some structure, and that has definitely changed over the course of the last almost year now, and having to do that, respond to those issues.
Yeah, and there was a response to my comment that the burden is already happening. Carol points out that as many young people are experiencing severe anxiety, refusal to go to school, causing widespread truancy. I think it'd be important to deal with that or understand that from a behavioral health standpoint versus kind of a more purely truant standpoint, understanding that it's the behavioral aspect of their condition that's making it harder for them to return for whatever the hybrid or in-person learning models that are happening. I always think about kind of an exposure model. So perhaps there's an opportunity for them to come into the building when there's no other children in the building. Maybe their preferred teacher could meet them outside the building and kind of escort them in. And then, introduce academics later, that the first thing is just to get them re-exposed to being in the school, in the ritual of education, maybe having their special friend meet them and kind of walk them in. It's often just a threshold effect that if we can get them back in the building, what we find is that they kind of acclimate. And then it's reassuring the parent that the child is okay with that separation. And so I'll often encourage staff to take a picture of the child having fun, engaged in learning, so that we can also simultaneously reassure the parent who may also have some anxiety about having their child back in the building. And there's so much concern about how this disease spreads and in what ways families are potentially at risk if they have their children back in the school setting, which we know is so critical to their learning. So finding ways to try to reassure them in practical ways and understanding what their specific concerns are, because each family has different risk factors that they are managing.
Thanks, Christopher. Christopher, I just wanted to add, my son's been attending in-person learning. He's in high school, and two of his closest people, his girlfriend and his best friend, are under quarantine right now because they've been exposed. So he's still going to school, but just a matter of time. Yeah.
I mean, it is interesting too, because I've had families. So one of the services that our agency provides is also a therapeutic school. So these are children who were not able to be successful in their public school setting. We serve over 45 different districts in the eastern side of Massachusetts and north of south of Boston. We're based in Boston. And we've had now 4 students that have tested positive. And I believe we've had 8 staff at this point, including 3 staff that seem to have an in-school transmission cluster. And the very first student we had, it was his mom who had tested positive. She alerted us. We then did the contact tracing, isolated him, but he was on a van for 30 to 40 minutes with 3 peers and a bus driver and a classroom. And he was the only one that came down with or tested positive for COVID. He actually had an asymptomatic case. And he had 2 siblings and mother's partner in the same household, and they didn't end up testing positive or developing COVID. So, and I've heard other stories like that. My niece, who works in a nursing home, ultimately got COVID. But her boyfriend and her housemates, none of them tested positive. And even someone else that I work with, his son developed COVID, and his twin brother did not, and nor did his parents. So it's interesting, as transmissible as this virus is, there's also these circumstances where even when there's been someone who tests positive or develops COVID symptoms in the household, isn't necessarily spreading it even within their own household. So it's a little confounding. So I do share those stories just to say, even when COVID touches your family, if you're able to isolate within the household, as challenging as that can be, living under one roof, we're finding that it doesn't necessarily mean that the entire family will come down with it. And so if that's able to reassure people somewhat about the relative safety. And I think this is a decision that people are going to make individually. So of our population of 105 students that we serve, 15 families are choosing to be fully remote. And we're doing a week on, week off schedule of remote and in-person learning.
You know, I think one of the things that we've tried to think about in Vermont with the learning, whether it's hybrid or in person, depending on the grade level here, is how do we really infuse, we have a multi-tiered systems of support within education. I think that's pretty common, positive behavior intervention and support being one, focus on behaviors. But how do we really infuse that more with some mental health consultation to really have the educational system understand, again, like I was saying, what are we seeing in students, but how can we best support students? Everything that you were just talking about around the progressive working back towards a comfort level of being in school. I think there's going to come a time when they can go back to school, and they can go back to school without masks. And even my conversations with my daughter, she's like, that's going to feel really weird. I'm worried that I'm going to be still reactive about, keep your distance. And I think a lot of parents, were concerned about what impact will that type of protective right now experience with that kids and all of us are engaging in have in the long term, right? Because we know that sometimes our protective actions can become problematic down the road if we don't readapt to the new situation. And so how do we talk about that and prepare and set the environment up in a way that really supports that adaptation?
Yeah, I completely agree. I was just reading an interesting piece about when will we know whether or not it's safe to have all students in schools full-time in-person learning. And then that's even before taking our masks off. Mm-hmm. And I think it's going to be a gradual process as we get the vaccinations out and we hopefully get to some degree of herd immunity. And we see in herd immunity, we'll know where we're at because those viral rates, positive transmission rates will go screechingly to a halt or as near to a halt as we're going to be able to get with a pandemic, with a completely novel virus. So, I'm thinking and what I'm hearing the good Dr. Fauci and others say is, we're probably talking about late summer, fall for whatever this new normal is going to look like. And I think, I think we're still trying to envision what new normal looks like coming out of a pandemic. I mean, I find it exciting just to begin to think about that and what we can start doing again together and start being with each other. And then, anticipating or planning for what's going to be for some students, particularly, unfortunately, again, marginalized populations, Black, Indigenous, people of color, poor students, maybe as much as a year of lost learning over this pandemic. And so what are we going to do about that? You know, are we going to think about extending schooling for another year? Are we going to be creative about what kind of a gap year and what opportunities will be available? I think while we're still managing the crisis, we're not able to even start visualizing, but I think the time to start visualizing is now about what we want this post-pandemic world, both in terms of, you know, telebehavioral health, but also taking that trauma-informed perspective. What are going to be the things that are going to be most helpful in preventing that traumatic experience from becoming a post-traumatic or ingrained behavioral health disorder? And I think that's where we want to think about what we know about what builds resiliency, what we know about can almost inoculate people from traumatic experiences. So I think our time is just about up. So I'm going to turn this over, unless anybody, each of you want to make one final comment before we send this to, and the group to their break before the afternoon workshop.
I just want to say from Michigan, I really appreciated being invited and happy to take any questions. I believe our contact information is available, and we really want to also learn from other states as well. So lots of great ideas out there. So we'd like to keep this conversation going. Thank you very much. Mary, anything you want to add from Michigan?
No, I think that does it. Thank you. Thank you for the opportunity to share, and love to hear from others.
Same from Vermont. I think we each have some different areas of focus in our states, but there's definitely some commonalities where we can share, and I'm glad to pass on any resources as needed. Thank you.
Yeah, and I'll just say it's been my pleasure talking with all of you and presenting with my co-presenters. We will be now transitioning to the break, and I think there's some information about that that's going to come right now.
Yes, I would just first thank you to our outstanding presenters for sharing their experiences and strategies with us today. And I would like to thank all of you for joining us for this segment of the Training Institute's Live. We hope that you take advantage of the wellness break before you join the next set of workshops that will begin at 3:30. If you have not registered for one of the two workshops, it's not too late. The links for the wellness break and the 3:30 workshops are in the chat. It's the link to the ideas at the Institute. You can also register for future workshops using this link. Also, we would very much appreciate you taking a few moments to complete the evaluation for this workshop using the link that was also posted in the chat. Your feedback will definitely help us shape upcoming workshops in this series. Again, thank you for joining us today, and we look forward to seeing you again after the break and on the first Thursdays of every month for Training Institutes Live.